Hi everyone, my name is Leah Scambato and I am presenting today on alpha thalassemia. What is thalassemia? It refers to a spectrum of disorders characterized by a reduced or absent production of one, rarely two or more, of the globin chains, thus disrupting the balance between the production of alpha and non-alpha globin chains. It is one of the most common monogenic disorders in the world, and estimated that nearly 70,000 children are born each year with various forms of this genetic disorder. The two most common forms of thalassemia include alpha and beta thalassemia, and today I will be focusing in on alpha thalassemia. It is an inherited genetic disorder caused by an impaired or absent production of alpha globin genes, which leads to an excess of gamma globin chains in the fetus and newborn, and excess beta globin chains in children and adults. The genotype and phenotype correlation of alpha thalassemia. It is a profoundly heterogeneous autosomal recessive disorder. And because the alpha gene locus is duplicated in humans, each individual normally carries four functional alpha chain genes. And on the basis of the numbers of alpha globin genes lost by deletion or totally or partially inactivated by point mutations, alpha thalassemias are classified into two main subgroups: alpha positive thalassemia, in which one pair of the genes is deleted or inactivated by a point mutation, or alpha zero thalassemia, in which both pairs of the alpha globin genes on the same chromosome are deleted. The clinical severity of alpha thalassemia depends on the number of functional alpha globin genes, as you can see here in this table provided. The presence of three functional alpha globin genes produces a very mild hematological changes and is known as the alpha thalassemia silent. Two functional alpha globin genes, either caused by heterozygous alpha 0 thalassemia or homozygous alpha positive thalassemia, or three functional alpha globin genes caused by heterozygous alpha positive thalassemia. These result in asymptomatic microcytic anemia and are referred to as the alpha thalassemia trait. Moving on, the inheritance of a single functional alpha globin gene, as you can see here in this table, leads to hemoglobin H disease, whereas complete absence of functional alpha globin genes caused by homozygous alpha 0 thalassemia deletes all four genes and leads to a lethal form of perinatal anemia called hemoglobin Bart Hydrops fetalis syndrome, which I will discuss all of these in detail throughout the presentation. This is a map that shows the genetic variants of alpha thalassemia. Alpha-positive thalassemia refers to more than 15 different genetic mutations that result in decreased production of alpha globin, which is due to a deletion of one of the two chain loci on the affected chromosome 16. Thus, there are three general forms of alpha-positive thalassemia, which spread high frequency, about 80% across the tropical belt from sub-Saharan Africa through the Middle East, South Asia, and Southeast Asia. Alpha-positive thalassemia, which again include alpha thalassemia silent, alpha thalassemia trait, and the hemoglobin H disease, are the most common of all single gene disorders. The alpha zero thalassemia refers to more than 20 different genetic mutations of the alpha globin locus that result in the deletion of both alpha globin chain loci on one chromosome 16. This is a map that just shows prevalence of hemoglobin Bart Hydrops fetalis. And this is also a map that shows the prevalence of hemoglobin H disease. So we move on to the genetic mechanisms, the role of HbA1 and HbA2 in alpha thalassemia. As mentioned earlier, alpha thalassemia is caused by reduction or absent production of the alpha globin chains due to a deletion or mutation of one or more of the four alpha globin chains located on the short arm of chromosome 16. The HbA1 gene provides instructions for making a protein called alpha globin. This protein, also produced from a nearly identical gene known as HbA2, are both located close together in a region of chromosome 16 called the alpha globin locus. Deletions of both HbA1 and HbA2 genes are the most common cause of alpha thalassemia phenotypes that I previously discussed. People typically have two copies of HbA1 and two copies of HbA2 gene in each cell. So there are four alleles that produce alpha globin. The different types of alpha thalassemias mentioned are a result from the loss of some or all of those alleles. The hemoglobin Bart Hydrops fetalis syndrome, the most severe form of alpha thalassemia, results from the loss of all four of the alpha globin alleles in HbH disease, which is milder than HB Bart syndrome, is caused by a loss of three of the four alpha globin genes. The types of alpha thalassemias. seen here are so as you can see in this table, phenotypes of alpha thalassemia range from asymptomatic to lethal, and the severity of the disease is well correlated with the number of non-functional copies of the alpha globin genes. And you will also see that there are non-deletional mutations, which are those point mutations, and I will discuss those a little bit later in this presentation. So the alpha thalassemia trait in the silent carrier. So clinical manifestations include mild hypochromic microcytic anemia. Your hemoglobin is typically greater than 10, and there's not a large component of ongoing hemolysis. The silent carrier is a benign carrier state, which affected individuals are not anemic, and the red blood cells are not microcytic, and your hemoglobin is normal. So diagnosis. Most individuals with thalassemia trait are found incidentally when their CBC shows a mild microcytic anemia, for example, during a routine health screening or during antenatal testing. Your peripheral blood smear will show red blood cell morphologic changes that are less severe than in affected individuals. You will also see hypochromic and microcytic red cells, but you will not see erythroblasts. And your mean corpuscular value will be between 60 and 75, and a hematocrit between 28 and 40%. The hemoglobin H disease is the loss of 3 alpha chain genes, which leads, like I said, to hemoglobin H disease. The genotype can be deletional or non-deletional, such as the hemoglobin constant spring, which is the most common form of non-deletional HbH disease. The phenotype of HbH disease varies, and although clinical features usually develop in the first years of life, it may not be present until adulthood, or may be diagnosed during a routine hematologic analysis in an asymptomatic individual. Non-transfusion dependent. It is a non-transfusion dependent but may require episodic transfusions during periods of increased hemolysis, such as an infection, pregnancy, or rarely aplastic crisis. Clinical manifestations include a microcytic hypochromic anemia, mild jaundice, splenomegalia, gallstones that are due to infections, and mild skeletal changes, including hypertrophy of the maxilla, bossing of skull, and prominence of malar eminences, which affect the facial features. The hemoglobin Bart hydrops fetalis is the most severe form of alpha thalassemia with deletions of all 4 alpha globin genes. It is severe anemia that occurs in utero that results in the fetal hydrops, and without intrauterine blood transfusions and regular transfusions after birth, these patients cannot survive, and most die in utero between 23 and 38 weeks. The clinical manifestations include being pale, retardation in brain growth, inactive infants with inappropriate growth and development, moderate to marked jaundice, gross enlargement of the placenta, prolonged intrauterine anemia, and a pronounced hepatosplenomegalia. You'll also see skeletal changes that include deformities of the long bones, especially in the legs, and craniofacial changes including frontal bossing, malar prominence, depressed nasal bridge, hypertrophy of the maxilla, and that tends to expose the upper teeth. And actually, according to Peel and Weatherall, a few children with hemoglobin Bart hydrops fetalis who received intrauterine transfusions and transfusions immediately post-delivery have been shown to survive to up to 5 years of age. And as you will see in this picture here, on the left side in A is a picture of a peripheral blood smear with immature red cell precursors and hypochromic microcytic red cells that show anisocytosis and poikilocytosis. And in B, that shows, unfortunately, a stillborn hydrophic infant. So the non-deletional alpha thalassemia typically occur in critical regions of the alpha 2 or alpha 1 genes, which cause non-deletional alpha thalassemia. The hemoglobin constant spring is the most common form of non-deletional alpha thalassemia, which is prevalent in about 2% of the northeastern Thailand population and 5 to 8% of the southern Chinese population, and about 1/4 of women in an ethnic minority population from Vietnam. The non-deletional alpha-positive thalassemia is associated with a higher degree of morbidity and mortality than deletional forms of alpha-positive thalassemia. Detection and screening for this type of alpha-positive thalassemia is more expensive as it requires DNA sequencing. In the presence of 4 very closely homologous alpha globin genes and the frequent coexistence of deletional forms of alpha thalassemia present another complexity in the detection of these point mutations. So that we move forward to the diagnosis and management. An interpretation of a peripheral blood smear. Typical red blood cell morphology in these alpha thalassemias demonstrates microcytosis, hypochromia, anisocytosis, which is a variation in cell size, poikilocytosis, which is the variation in shape, and evidence of hemolysis, such as an increased reticulocyte count, about 5 to 10%, in nucleated red blood cells. The staining of peripheral blood cells with 1% brilliant crystal blue is sensitive to visualize the inclusion bodies that are seen in red cells. And the microcytes can be evaluated by comparing the size of red blood cells with those of small lymphocytes. And hypochromic red blood cells are those with increased diameter of central pallor red blood cells, which are more than 1/3 of their diameter. Anisopoikilocytosis results from various abnormal red blood cell morphology, which include schistocytes, microspherocytes, target cells, polychromasia, and nucleated red blood cells, which are erythroblasts. And the number of the erythroblasts is markedly increased after a splenectomy. And you'll also see in HBH disease, the degree of an anisopoikilocytosis varies according to the degree of hemolysis. And the typical inclusion body cells have golf ball-like appearance with stippling regularly distributed over a blue-stained background. More diagnostic criteria includes the hemoglobin analysis, which is important laboratory evaluation to provide presumptive identification and diagnosis of thalassemia. Clinical information that is necessary for an analysis includes your age, ethnicity, the history of the onset of anemia, pregnancy status, the history of blood transfusion, as well as the date of the most recent transfusion if you had one, and a family history. The qualitative and quantitative hemoglobin analysis is either done by cellulose acetate electrophoresis, weak cation, high performance liquid chromatography, isoelectric focusing, and citrate agar electrophoresis, which identifies the amount and type of hemoglobin present. The degree of microcytic hypochromic anemia depends on the number of the genes that are mutated, and a combined use of the HPLC and electrophoresis to separate abnormal hemoglobin fractions is important in individuals with HBH disease. Excuse me. The DNA and the molecular analysis. So the GAP PCR was developed for the 7 most common alpha thalassemia deletions and a reverse dot blot for non-deletional mutations. And for unknown mutations, southern blotting and multiplex ligation dependent probe amplification analysis and gene sequencing must be done. Further diagnosis and management is the alpha-beta globin chain synthesis, which measures the ratio of alpha and beta globin chain synthesis, which is the most direct approach at the protein level to diagnose these alpha thalassemias. And Weatherall and Clegg first described this procedure in 1965, which consists of several steps, including removal of white blood cells, reticulocyte enrichment, in vitro globin chain synthesis in the presence of radioactively labeled leucine, separation of the newly synthesized radioactive labeled alpha and beta globin chains, and a measurement of the radioactive signal. And if the alpha-beta ratio appears lower than 0.8, it's indicative of alpha thalassemia. A ratio around 0.75 is consistent with the loss of expression of a single alpha globin gene. In a ratio of 0.5 is indicative for 2 alpha globin genes, and 0.25 for 3 alpha globin genes. So management. The carriers of alpha positive or alpha 0 thalassemia generally don't need treatment because their anemia is so mild. They can be anemic because of coexisting nutritional deficiencies such as iron, folate, or B12 deficiencies, which should be managed from that standpoint. In the HBH disease, you can have intermittent blood transfusion, especially during intercurrent illness, and a chronic transfusion is often uncommon in this group, but patients with non-deletional types of HBH may have more severe splenomegalia and require more transfusions. In addition, iron overload is uncommon in HBH disease, but it has been seen in older patients greater than 45, in which iron chelation therapy should be initiated. And this is iron overload is seen when there is transfusions of 20 to 25 units of blood. In the HB Bart's hydrops fatalis, most pregnancies which this is diagnosed have terminated. So intrauterine blood transfusions following early detection of homozygous alpha-0 thalassemia has resulted in the birth of non-hydrophic infants, some without significant neurological or congenital abnormalities. But affected infants that do survive are good candidates for hematopoietic stem cell transplants. And this often, the HB Bart's hydrops fetalis often causes obstetric complications and the need for long-term transfusion therapy. Those are both arguments for counseling and selective abortion. So then we go on to the ethical, legal, and social considerations. In the absence of specific treatments and a clear understanding of the underlying mechanisms that are responsible for the congenital abnormalities associated with the HB Bart syndrome, preconception genetic screening and early prenatal diagnosis are necessary to identify at-risk pregnancies. Prenatal screening is offered when both parents are found to be carriers of the alpha-0 thalassemia trait, which is most important of individuals in Southeast Asian origins. So, with the detection of HB Bart hydrops fetalis syndrome through prenatal screening, termination of pregnancies is usually recommended, with consideration to the increased risk of maternal and neonatal complications, as well as the psychological effects on families. However, with religious backgrounds, we need to be careful. They need to be carefully taken into account because when counseling these at-risk couples, they may still choose to continue with the pregnancy, knowing the risks of toxemia, postpartum bleeding, neonatal death, or even maternal morbidity. A correct diagnosis early in pregnancy is crucial to avoid severe medical complications and psychological trauma, and it can be made with relatively low cost, provided that the pregnant woman does receive regular follow-up care. Recent progress in DNA testing has demonstrated a greater phenotypic diversity in HBH disease than previously thought. So it's important to conduct a DNA analysis to identify the underlying genetic variant that causes these non-deletional forms of alpha thalassemia. But the caveat is that the gap polymerase chain reaction and the multiplex PCR assays that allow for easy screening for a range of the common variants remain very costly and are not widely used in low and middle income countries. And even though DNA testing methods are becoming more affordable, it is likely that these will become a regular part of services available for the control and the management of thalassemias, particularly where we often see these in Southeast Asia. And that concludes my presentation on alpha thalassemia. Thanks so much for your time.